This is the operating room of Beijing Antai Hospital. We are performing a cervical cerclage procedure on a patient who is 25 weeks pregnant and experiencing cervical dilation with protrusion of the fetal sac into the vagina. This procedure is commonly referred to as a rescue surgery. As many of you may know, the anti-cervical cerclage is an excellent technique for preventing late-stage miscarriage and improving cervical laxity. We offer a contracted treatment plan, and if the desired outcome is not achieved after the surgery, a full refund will be provided. If the patient experiences a subsequent miscarriage after the surgery, a full refund will also be issued. However, it's crucial for patients to understand the timing of this procedure. When we refer to the contracted treatment for a subsequent miscarriage, we are specifically addressing the placement of the anti-cervical cerclage before or during the early stages of pregnancy. This procedure involves placing an anti-ring at the internal cervical os. The ring effectively prevents the automatic dilation of the cervix in the later stages of pregnancy and pathological shortening of the cervix due to fetal weight and gravity. For patients experiencing mid to late pregnancy miscarriage risk or cervical laxity, a rescue anti-cervical cerclage may be necessary. What does rescue mean in this context? It refers to cases where the cervix has shortened somewhat during the middle stages of pregnancy, but the fetal sac has not yet protruded into the cervical opening or entered the vagina. In such cases, a rescue anti-cervical cerclage is performed. The success rate for this procedure is relatively high, around 80 to 90%. However, we are unable to offer the contracted treatment in such cases due to the increased risk associated with the already shortened cervix. In situations where the cervix is completely dilated and the fetal sac has entered the vagina or fully entered the cervix, a more challenging rescue procedure is required. Our approach to this surgery differs from conventional procedures. We utilize an inverted position, which naturally empties the cervix. Afterward, the anti-cervical cerclage is placed at the internal cervical os. The success rate for this procedure is around 70 to 80%. Nevertheless, there are two potential risks that we must avoid during the surgery. The first risk is premature rupture of membranes. This can occur due to imprecise manipulation or if the fetal sac is already fragile. In such cases, infection is likely, leading to premature rupture. This could result in a failed surgery. The second risk is secondary damage, including bladder injury. Bladder injuries can lead to hematuria, abdominal pain, and pelvic infections, which may also result in a failed surgery. Additionally, if the ureter is entangled, compressed, or damaged during the procedure, it could cause hydronephrosis. To prevent these complications, immediate urine tests are conducted intraoperatively and postoperatively within 3 days. If microscopic hematuria is present, it could indicate urethral or bladder injury. Furthermore, continuous renal pelvis and ureter ultrasound scans are recommended within the first 3 days post-surgery. Detecting hydronephrosis or kidney pelvis dilation is crucial. Some patients may experience lower back pain or discomfort. In such cases, the diagnosis of entangled ureter must be made promptly, requiring immediate secondary surgery or removal of the anti-cervical cerclage to allow for natural miscarriage. If conditions allow, a double cerclage may be considered, involving the placement of a new anti-cervical cerclage alongside the original one. This decision depends on the specific surgical circumstances. Post-surgery, daily inversion is recommended to naturally draw the fetus downward due to gravity, thereby expanding the uterine cavity and reducing cervical pressure. This plays a significant role in subsequent maintenance of pregnancy. Additionally, the real-time use of atosabin to prevent contractions has proven highly effective. As of now, it has been 7 days since the surgery, and the ultrasound shows that the anti-cervical cerclage is securely in place at the internal cervical os. This rescue surgery has been successful, ultimately saving a precious life.